Okay, guys, so for those of you who don't know me, my name is Mahmoud. I'm one of the second years. Today we are going to continue talking about emergent fluorescence, and our topic today would be about acute respiratory failure. Before we move on with our presentation, I would like just to touch base on some of the basics that you probably know. But just when we say acute respiratory failure, we mean two types of respiratory failures. It's type 1, which is hypoxic or hypoxic respiratory failure, which means we have an issue with oxygenation. And when we do that ABG, the VaO2 would be less than 60. And as you already know that when we try to modify oxygen, we can do this by two things: either increase FiO2 or increase the speed, which is mean positive pressures in the airway. This is how we control O2. Second type of the second type of respiratory failure is type 2, which means hypercapnic. And in this type, we have an issue flowing out CO2, and it means that the PCO2 would be more than 45. And we have an issue of ventilation. So type 1 issue with oxygenation, type 2 would be an issue with ventilation. And usually we control CO2 by two things: tidal volume, respiratory rate. We control CO2 by doing that. Either we increase respiratory rate to wash out CO2, or we increase our tidal volume. Okay? So before we go on, let's say we got okay. So you are on call in the middle of the night, or like you are day call, and you got a page from the nurse saying that your patient is decompensating on the floor, and you don't know anything about this patient. You are just covering for the day or for the night. So first thing to do is to assess the situation. Okay, or either call your same. So you assess the situation by you call the nurse and ask her to give you like a quick rundown about what's going on, last set of vitals, his mentation, active complaints, like to assess the situation and assess the urgency if you need to intervene right away, or you have a couple of minutes to like review the charts. But first, let's talk about different modes of oxygen delivery. So we can divide it into three main categories. First is the conventional, and I mean like if we draw like a line like this, we have first thing is nasal cannula, which can provide flow rate 1 to 6 liters per minute, and it can give us FiO2 from 20 to 40%. Actually, it's 21, which is the room air, but just to make it easy, it's 20 to 40%. Then we have the venturi mask or the venti mask. It can go from 6 to 10 with FiO2 from 40 to 60%. Then we have the non-rebreather mask, which has a reservoir bag, non-rebreather. It can go from 10 liters to 15 liters, and FiO2 to 60 to 80%. So when the nurse calls you and she panics that your patient desaturates in room air, what you can do, like, just ask her to throw on another breather for 10 minutes. It's gonna give you a couple of minutes to review the chart. Even if your patient has COPD and he is dependent on the hypoxic drive, 10 minutes won't shut down the drive. So it's gonna buy you some time. This is the conventional. Then we move on to non-invasive ventilation, and we have here high flow nasal cannula, which which can go from flow rate from 15 to 60 liters per minute. And of course, FiO2 from 21 room air up to 100% FiO2. Then we have the CPAP machine, and we are going to talk about the difference between the CPAP and the BiPAP. This is the non-invasive ventilation, and when you reach this point, you should consider escalating level of care. It doesn't mean that your patient is crashing right now, but it means that he has a high risk of decompensation, and you should think about escalating level of care. Always be bright. Then the last thing, it means that he already went to the ICU intubation. Okay, so this is the escalation of the oxygen therapy from nasal cannula up to intubation. I'm going to talk a little bit about the difference between CPAP and BiPAP. I know that we have a lecture later today with Dr. Brown-Vitz about obstructive like heart disease, lung disease, and most likely he will touch base about the BiPAP and CPAP in great detail, but just quick things about CPAP and BiPAP. So for CPAP versus BiPAP. From the name, this is bi-level positive airway pressure. So we have two settings that we can control here. We have the EPAP and we have the IPAP. And I'm going to talk a little bit later about both of them. And this is continuous positive airway pressure. And we have one setting here. It is the PEEP, or positive airway pressure. And just think about this. Your lungs works like full expiration and then inspiration, and you like inflate your lungs. What we do is that we provide positive airway pressure, so we prevent full collapse after full expiration. So it means that your lungs will be open to some extent after full expiration, and by doing that, you have two benefits. The first one is that you are going to recruit more alveoli and open up lungs for acid gas exchange. And the second benefit that you will increase the intrathoracic positive airway pressure, and theoretically will decrease the preload and help with the cardiac output. So CPAP mainly beneficial for PHF for the reasons that I already mentioned, positive airway pressure, decrease the preload, and was also very beneficial for obstructive sleep apnea because you are simply keeping the airway structure open and they are not collapsing. So they are very beneficial for obstructive sleep apnea. And you can control the beat from 5 up to 20 to 25. Of course, it's centimeter H2. IPAP has two settings. You can think about the IPAP, the EPAP as equivalent to the beep. It simply has the same function as the beep. And the IPAP, we can do something like here. This is the pressure, and this is the time. Here we have the baseline respiratory cycle, like this, like inspiration, expiration. By applying positive airway pressure, you are reset the baseline to a higher level, so the cycle will be like this. You are increasing the functional residual capacity. So you have airway pressure all the time. You are not fully collapsing after full expiration. This is the CPAP. The difference that with IPAP, you have something like this. So this is the IPAP, and this is the EPAP. And you can set both of them in the settings of the machine. And the difference between the IPAP and the EPAP is called pressure support over beep, or pressure support. It means the tidal volume. So you can control actually the tidal volume by applying both IPAP and EPAP, and by titration of the IPAP, making a huge difference between both settings, you control the tidal volume. We will see in the slides. So let's go back to our presentation right now. So you get this page in the middle of the night about patient decompensating on the floor. We talked about assessing the situation. So we already discussed this about different modes of ventilation, of oxygenation, from nasal cannula up to intubation. This slide, which I already talked about, normal breathing and the beneficial of applying positive pressures for CPAP, and the difference between CPAP and EPAP by applying bi-level positive airway support, and by increasing this gap between EPAP and IPAP, we're actually controlling the tidal volume and blowing more CO2, since we already said that we can control CO2 by increasing either tidal volume or respiratory rate. So also this slide is very beneficial about talking about difference between CPAP, BiPAP, and high flow nasal cannula. CPAP mainly for type 1 hypoxemic respiratory failure. BiPAP can be used for type 2 or mixed combination of type 1 and type 2. And high flow as well can be used with alternation for CPAP for type 2 or for purely type 1 hypoxic respiratory failure. So situation, talk to the nurse, assist urgent situation, background. So we say that we have 60 years old male, past medical history of coronary artery disease. And hip, wrist, COPD, and he has a history of prostate cancer as well. So first thing, after you spoke with the nurse, told her to throw on another breather, you open the chart, take a quick look at the labs, last set of vitals, recent imaging, and last progress note. By doing that, you will figure 99%, you will figure out the underlying cause of the rapid decompensation. Okay? After doing that, you go at the bedside and assess the patient. But since we're already here, what is the most common cause for acute hypoxic respiratory failure? Like if we are talking about differential, your patient has acute hypoxic respiratory failure. What is the most common etiology? Anyone, guys? Anyone? CHF exacerbation. What else?
For acute hypoxic respiratory failure.
In general, like anything can cause hypoxia. So we can make it like broad. Anything that can cause pulmonary edema can cause acute hypoxic respiratory failure. Okay, so what about hypercapnia? Acute, like type 2 acute respiratory failure, which is the main thing is high CO2 or hypercapnia. What do you think of when we say acute hypercapnic respiratory failure? COPD, which is the most common thing that you will see on the floor. Hypoventilation syndrome. Narcotics, anything that can decrease the respiratory drive can cause hypercapnia. And of course, asthma exacerbation. So this is the most common differentials. I already highlighted the most common things that you will see on the floor actually. So cardiogenic pulmonary edema for any reason like congestive heart failure, acute decompensated heart failure, pneumonia, heart for multiple reasons of course. Pulmonary embolism actually can cause both hypercapnic and hypoxemic respiratory failure. For the hypercapnic, what I want you to know is the COPD exacerbation and asthma exacerbation, and as you mentioned, OHS. Many causes, but I'm talking about the most common things that you will see on the floor. Okay. So anyone can interpret the ABG. So this is in the morning, and this is when the nurse called you about the patient is decompensating on the floor. Hey, Rabina, what do you think about this ABG?
What?
It is the same patient. So this is what happened over time.
Okay. Going back to the history that we already, that he has coronary artery disease, hip rip, COPD, history of prostate cancer, and you right now see this ABG. What do you think is the most like common underlying process that's going on right now? Could be COPD exacerbation, right? I can't hear you actually.
What do we make of the oxygenation on that?
So he's over oxygenated right now.
That is 40%
Mm-hmm.
He's asking, is that like 2 liters?
Could be 2 liters, yeah, I think so. 2 liters.
Hyperoxygenate these guys because again want to decrease the respiratory drive.
So-
want to worsen the carbon dioxide.
So what I told them already earlier, over oxygenating your patient for 10 minutes or 15 minutes won't shut down or shut off the respiratory drive. So just over oxygenate until you figure out what's the underlying cause. Then you can, when we use this step by step, we are just supporting his respiration. We have to reverse the underlying process. So whenever we use like CPAP or BiPAP, it's not going to be helpful for too long unless we figure out what's the underlying process and we reverse it. Okay? So you went at bedside. What do you want to do? What are you looking for? Your patient, the nurse called you, decompensating, you entered the room. What do you want to do? Any idea, guys? Mm-hmm. Okay, good. Anything else? What else? Like, I need everyone to tell me something. Vital signs. Mm-hmm. Mm-hmm. So you are listening, auscultating the lungs. What else? Signs of cyanosis. Okay. Uh-huh. What else? Yes, that's a very important thing to do. Look at your patient, see if he's exerting himself. Look at the accessory muscles, if he's using the accessory muscles. Paradoxical respiration, like he's using his abdomen, like his abdomen is going up and down. Retractions of intercostal retractions, like look for signs of accessory muscles use. What else would you like to look for? I think you already mentioned a lot of things. So first of all, you have to assess his mentation. Try to assess his GCS first, because this is going to be very helpful to assess or determine your next step, whether you need to escalate level of care or he can be managed on the floor. So you assess his GCS and you found that he is responsive and he's doing fine. Then you do a thorough physical exam, listen to his lungs, listen for crackles so you have CHF, salivation, wheezes. If he exerting himself, like his respiratory rate is in 40s for too long and he is like tiring out, you look at all of this. Tachypnea, dyspnea. This is
you see as indicates that patient should be evaluated for intubation.
Mm-hmm.
Is your CS number?
8 intubate. Okay, so the first thing you do, you assess his GCS.
Almost thing is that get an ABG. Like now here we have the ABG, but like you need the numbers to know. So if you don't have a recent ABG, ask.
So the ABG, you can do it in either two ways.
About ISTAT, you want to talk about that?
Okay. So the ABG, you can, when the nurse calls you and tell you the situation, you can ask her to, you put in an order for ABG or ask the nurse to put an order for ABG. Or if you think that you can go at the bedside and assess him, you assess the urgent situation, do a physical exam, then order ABG. So it can go either way. You can do it right away when she calls you and you think it's danger, or you can wait until you assess at bedside, then you do all the workup you want to do. Okay? So I said that Abdullah mentioned about.
So yeah, there's the ABG usually is the lab, so the phlebotomy would come up at bedside, draw the blood, send the sample to the lab will run the ABG, and it usually takes 20 to 30 minutes. But if you have something that's acute, that you say the low spending is about the patient is about to be intubated or currently unstable, there's something called an ISTAT. And what is that is when the phlebotomy comes through, they bring a machine with them. So they would do the arterial sample from the patient, and they would run the sample right there, and it takes 5 minutes instead of the 20 minutes. So that's another option that you have that you can be aware of. Do you think any electrolyte, I will have the electrolyte, hemoglobin, and an EVG? If you need anything urgent, this is another option that you should know of that it exists.
Do we have to follow rapid when we bring the ISAT?
Doesn't matter, I don't know. If you need an ISAT, just forward, tell the nurse. But usually, all of these situations is probably a rapid response if the patient is acutely compensated. Exactly, yeah.
Sometimes, you know, we used to go into the most of them are the hospital physicians, but now they're calling rapid overhead, so you can use it. But yeah, you should know that you can understand.
If your patient is unstable and you need to see the labs right away, you can call ISAT. Okay?
Yeah. If you know how soon you want to, you're more than welcome
Not
to.
that one, two, but maybe.
Usually they're right there. Like whenever they call a rapid response or code blue, we have an on-call team that responds, and if the bottom we have an on-call team that responds. So they are there as soon as you.
Okay. So we move on to the workup. You saw your patient, you assess him clinically, and you do like review chart. What workup would you like to do right now? The first thing that you would do is ABG. Your patient was on room air, and you put him on runner breather. Your patient on CPAP. You usually get an ABG 1 hour after you do your intervention to assess like the beneficence of what you did. Okay? So ABG first. What else would you like to order if I'm saying that this patient you suspect CHF exacerbation? Chest X-ray, of course. If you have high probability for PE, you think it's PE, you will order CTA state. Depends on the underlying process. It's gonna guide your further workup. Okay? This is the most important slide, and I need all of you to remember this. We all need to take the decision to move on from non-invasive ventilation and into intubation proactively, as opposed to wait until your patient crashes on the floor and we urgently intubate them. Always be proactive. And I already mentioned, when you are titrating aggressively from nasal cannula up to CPAP or BiPAP, you should think about escalating level of care. It doesn't necessarily mean that your patient needs intubation right away, but it means that he needs higher level of care, frequent observation or monitoring. Okay? So what are the things that will make you take the decision to move on to intubation or saying that non-invasive ventilation is not enough right now? First thing, when hypoxemia or hypercapnia persists despite aggressive titration, like you went to 100% FiO2, high flow nasal cannula or BiPAP or whatever, and your patient still desaturating, exerting himself. This one thing you look for. Second thing, if your patient is having nausea or emesis and you consider putting them on BiPAP, there is a risk of aspiration, so you should avoid doing that unless you are 100% sure that your patient is not like vomiting, actively vomiting, or having nausea. The third thing, if your patient is exerting himself, like tiring out, he's breathing fast in the 30s or in the 40s, and he has signs of fatigue, and you anticipate that he will crash at any moment, you should escalate level of care. The fourth thing that we already spoke about, that he cannot protect his own airway, let's say for any reason, like he has overdose, opioid overdose. He is unconscious. GCS is less than 8. This is the thing that you will think about when deciding escalating level of care or deciding on intubation. So always look for those 4 things when you assess your patient, because you have to be very proactive. You shouldn't wait too much before taking the decision. Okay? After you did all of that and you stabilized your patient, you review your workup, whatever you ordered, chest X-ray, ABG, CTA, whatever you did, you review that. Then this is the example of the orders itself. So you decide to put your patient on runner breather. The nurse would ask you, please put an order for oxygen therapy. So this is the order you will type oxygen order, and you will specify whatever you want, from nasal cannula up to non-rebreather or high flow. You mentioned the reason, oxygen, titrate oxygen to keep it above 88 or 88 to 92, and of course you know the indication for everything. This is the oxygen, the general oxygen order. This is the CPAP order, and you will find the most important thing is the beep. You can titrate up 5 to 20. You should also not go high up to 20 because there is risk of insufflation of the stomach and risk of aspiration. The sphincter has a pressure of 20 to 23, so you shouldn't go up that to avoid the risk of insufflation and aspiration after that. And this is, go ahead.
If you give Zofran or intubation,
I think you can.
I don't know if that affects again. I don't know if it's
Me too, actually. But if you think that your patient is at risk of aspiration, you shouldn't like risk giving him like the friend or put them on pipette. You should move on to intubation to prevent like injury to the lungs. Okay. The bypass, as we already mentioned, there's two settings that you can set up. Target tidal volume, which usually in 8 cc per ml. But the main two things that the IBAP and the EBAP, you can control both of them to improve your tidal, or like increase your tidal volume and wash out CO2. And I'm gonna give like quick example, like for EBAP, we can set up 5. EBAP, like the EBAP is equal to the beep of the CPAP, and it's gonna provide both the airway pressure. And the IBAP, actually, you can titrate up to increase the gap between the I and the E. By doing that, you're improving the tidal volume and you are washing out CO2. So let's say you set the EBAP at 5 and the IBAP at 10, and your patient is still hypercapnic, still retaining CO2. You can actually go up on the IBAP to increase the gap. By doing that, you increase tidal volume and you are washing out more CO2. But let's say you put your patient on BiPAP and he has CHF exacerbation, and you wanna recruit more alveoli and like enhance the acid-gas exchange. You will manipulate or modify the EBAP, the lowest number. So you can go up to 5, 10. Okay. So this is the recommendation. You assess your patient after the intervention. You review your results, and you assess the need to escalate the level of care. Of course, you will notify your senior about all of that, and you're attending about significant events, and you have to document all of that. And I mentioned here the dot phrase. You can go to like smart phrase manager, and you can share Abdullah smart phrase with you guys, so you don't need to memorize the actual dot phrase. What you need to do is just put an actual significant event, and it will auto-populate the whole significant event book.
And you can change it to your name.
You can change it to
just significant event, whatever you want.
I mean, I'm so lazy, I just keep it like this, and I memorize them. And that's it. Any question, guys?
Okay.